Hello everyone, my name is MMuratagic. I am a pediatric clinical pharmacist at St. Joseph's Children's and Women's Hospital, and today I'll be going over asthma with you all. I'd like to start off by stating that I have no relevant financial or commercial relationships to disclose in conjunction with this presentation. The objectives for this presentation are to review the epidemiology and pathophysiology of asthma and asthma exacerbations, to examine the clinical manifestation of asthma and asthma exacerbations, review the components of asthma management, evaluate pharmacological treatment options for long-term control as well as acute exacerbations, and lastly, to discuss delivery device options.
Asthma is a chronic inflammatory and bronchospastic disease of the airways, and it's the most common chronic disease of childhood, affecting more than 10 million children in the United States. Asthma is also the most frequent cause of hospitalization among children, accounting for around 500,000 hospitalizations and 1.9 million emergency department visits in 2009.
The pathophysiology of asthma involves mast cells, eosinophils, neutrophils, macrophages, and epithelial cells. These inflammatory and structural cells will collectively produce mediators such as cytokines, chemokines, and leukotrienes that intensify the inflammatory response and promote airway narrowing and hyperresponsiveness seen in asthma. And in susceptible individuals, this will cause recurrent episodes of coughing, wheezing, breathlessness, as well as chest tightness. The airflow limitation that is seen in asthma is caused by three main changes, including airflow obstruction due to the mucus response and hypersecretion, airway hyperresponsiveness in response to stimuli, as well as inflammation. And the chronic inflammation that patients experience can also cause airway remodeling. So the primary risk factors for asthma includes a history of atopic disease, such as eczema, history of recurrent wheezing, as well as a parental history of asthma. And risk factors for asthma-related death includes previous severe exacerbations, patients who've had 2 or more hospitalizations in the past year, or 3 or more ED visits in the past year, hospitalizations or ED visits in the past month, more than 7 canisters of short-acting beta-2 agonists per month, low socioeconomic status, as well as any psychosocial problems that may affect adherence.
The key symptoms of asthma are cough, a recurrent wheeze, recurrent difficulty in breathing, and recurrent chest tightness. Patients with asthma will have these symptoms that occur or worsen in the presence of exercise, viral infections, inhalation of allergens or irritants, changes in weather, strong emotional expressions, as well as stress and menstrual cycle. And these symptoms usually occur or worsen at night and awaken the patient. Diagnosis of asthma is based upon the clinical signs and symptoms, as well as pulmonary function tests. Spirometry testing is recommended in patients who are 5 years of age or older. Spirometry tests should be performed before and after administration of a bronchodilator to assess for reversibility as well as airflow obstruction. The definitions for airflow obstruction are based upon the forced expiratory volume in 1 second, and an FEV1 of less than 80% predicted is an indicator of airflow obstruction. And an FEV1 over the forced vital capacity ratio that is less than 0.85 is also defined as airflow obstruction. And these are good predictors of the risk for future exacerbation, as well as the degree of impairment. Spirometry should be done at the initial assessment, after treatment is initiated, during periods of progressive or prolonged loss of asthma control, and at least every 1 to 2 years in these patients. Spirometry usually cannot be performed in infants and children less than 5 years of age because these patients cannot control their breathing as well as older children. And therefore, in these patients, diagnosis can be made upon bronchodilator response, so the reversibility of symptoms after the use of a short-acting beta-2 agonist, as well as exclusion of alternative diagnoses.
So, asthma is the most prevalent chronic disease in children, and in majority of these patients, it starts before the age of 5 years. And as we just discussed, spirometry testing cannot be completed in patients who are less than 5 years. So it can be very difficult for physicians to diagnose asthma in infants and preschoolers, not only because they can't be assessed routinely, but also because their symptoms are variable as well as nonspecific to other wheezing disorders. The Asthma Predictive Index was developed, and it's a guide to determine which younger children will likely have asthma in later years. So, children who are younger than 3 or 4 years who have had 4 or more significant wheezing episodes in the past year are much more likely to have persistent and lifelong asthma after 5 years of age if they have either um, one of the major criterion, such as eczema or parental asthma, or two minor criterion, including allergic rhinitis, wheezing that's unrelated to colds, or a blood eosinophil count that's greater than 4%. So the Asthma Predictive Index was developed after following close to 1,000 children through 13 years of age. Of these, 76% of the children were diagnosed with asthma after 6 years of age if they had a positive asthma predictive index before 3 years of age. And 97% of those children who did not have asthma after 6 years of age had a negative asthma predictive index before 3 years of age. So this study found a strong argument for the use of the asthma predictive index in these younger patients to use it routinely to provide insight to providers and the physicians as well as parents to monitor these patients and their symptoms of asthma closely as they grow, and then if needed can start the medications earlier than waiting until age 5.
Now on to the management of asthma. The goals of management of asthma are to reduce impairment by preventing chronic and troublesome symptoms, requiring the infrequent use defined as less than 2 days per week of inhaled short-acting beta-2 agonists, maintaining near normal pulmonary function and normal activity levels, as well as reducing the risk, preventing exacerbations, preventing the loss of lung function and reduced lung growth, providing optimal pharmacotherapy with minimal or no adverse effects, and minimizing the need for emergency care or hospitalization. There are 4 components of the management of asthma. The first component is the assessment and monitoring, assessing for the severity of the disease, the control, and the responsiveness to therapy. The second component is patient education on their medication use as well as their asthma action plan. The third component is environmental control and management of any comorbid conditions. And the fourth component, and what we'll focus on in the presentation, are the medications.
So to properly treat a patient with asthma, the severity needs to be classified. Classification is based upon a patient's age. So there's 2 charts, one for child 0 to 4 years, and the other chart for children 5 to 11 years of age. For patients 0 to 4 years of age, the severity is classified based on the symptoms, the number of symptoms, the number of nighttime awakenings they experience, frequency of use of their short-acting beta-2 agonist, as well as any interference with their normal activity. So based upon the responses and the symptoms, the patient is placed into the most severe category. And then as you can see, the last row in this chart has the recommended step for initiating therapy. So for example, if we have a 3-year-old patient who has symptoms 1 day a week, experiencing no nighttime awakenings, using their short-acting beta-2 agonist maybe once a week, and has no interference with normal activity, we would classify this patient as having intermittent asthma. And then the treatment options we would look at would be those that are listed under step 1 of the chart on the next slide. So this chart shows you the management options for patients. And again, as we discussed, this will depend on the classification of their asthma. So based on the last row, for patients with intermittent asthma, they can be treated following the recommendations for step 1. So using a short-acting beta-2 agonist as needed. Those with mild asthma can be treated with recommendations for step 2, and those with moderate to severe asthma can be treated with step 3 options. These patients will require regular follow-up with their physician to determine their control of their asthma and see if there's a need to either move up or down any steps. So once a patient is started on appropriate therapy for their asthma, control will be assessed at each follow-up visit. So as you can see, the components for assessing asthma control are very similar to those when we're diagnosing a patient's asthma severity. So based upon the responses, there are different treatment recommendations to be followed, which we will discuss in the next slide. So after assessing a patient's asthma control, we want to make sure to review their adherence to their medications. Maybe they're not well controlled because they're not taking their medication their daily as prescribed. You also want to assess inhaler technique. Maybe they're not using their spacers or their mouthpieces appropriately, and so the patient is actually not receiving the majority of their medication, which could affect the way their asthma is controlled. And then you also want to assess the environmental control. Are they aware of their triggers? Ensure they avoid those triggers. And so these will all be discussed with the patients prior to making any recommendations for treatment. So as you can see here, treatment recommendations are based on if a patient's asthma is well controlled, not well controlled, or very poorly controlled, and either going up a step or 1 to 2 steps. And then, of course, we're reevaluating the patient more frequently if their asthma is very poorly controlled.
So this chart, as we discussed, is similar to the one for patients 0 to 4 years of age. However, this also includes the lung function test results, as these patients are able to do the spirometry testing.
So this chart is similar to the chart for the children 0 to 4 years of age. You can see the asthma management options is again based upon their severity and the step recommendation that should be taken for that severity. This chart, again, similar to the one for patients 0 to 4 years of age. Assessment of their asthma control is done at each follow-up visit, and based upon their response and their symptoms, we either move them up or down a step. So again, we want to make sure that we assess their medication adherence, their inhaler technique, as well as environmental control before making any recommendations if they are not well controlled.
Now on to the long-term control medications. Corticosteroids block the late phase reaction to allergens, reduce airway hyperresponsiveness, and inhibit inflammatory cell migration and activation. Inhaled corticosteroids are used for long-term prevention of symptoms, suppression, control, and reversal of inflammation. They're used daily, and they're the most potent and effective anti-inflammatory medication that's currently available. Inhaled corticosteroids can reduce impairment, reduce the risk of exacerbations. However, they do not alter the progression or underlying severity. Oral corticosteroids are used for prompt control of the disease, and short courses of oral systemic corticosteroids can be used before initiating long-term therapy. And long-term oral corticosteroids is really used for patients with severe persistent asthma. Here are the inhaled corticosteroid agents that are available, and the dosing for patients who are 0 to 4 years of age, as well as 5 to 11 years of age. QR is given as 2 to 4 puffs per day, depending on the dose. Budesonide nebulizer, as you can see, is the only inhaled corticosteroid with FDA-approved labeling for children less than 4 years of age. And budesonide can be given 1 to 3 times daily. Fluticasone HFA doses should be divided 2 times daily. And as you can see, there is a higher dose of fluticasone in children who are less than 4 years of age than for those children who are 5 to 11 years of age. And this is due to the lower dose delivered with face masks, as well as the data on efficacy in young children. Adverse reactions of corticosteroid, there's local reactions including oral candidiasis or thrush. This is the most common adverse effect, and it can be prevented by using a spacer or valved holding chamber with a non-breath activated MDI to reduce the incidence of colonization, as well as rinsing the mouth with water after inhalation. And then for patients with active infections, can be treated with topical or oral antifungal agents. Inhaled corticosteroids can also cause dysphonia, which is associated with vocal stress and increasing dosages of inhaled corticosteroids. And using a spacer or valved holding chamber, reducing the dose and resting for vocal stress. And inhaled corticosteroids can also cause a reflex cough. Systemic adverse reactions include glucose abnormalities such as hyperglycemia, mood alteration, and fluid retention. as well as linear growth reduction. A reduction in growth velocity may occur from the use of corticosteroids for treatment. The evidence available shows the effects are small and non-progressive, and it's important to remember that children or adolescents may have reduction in growth velocity just as a result from inadequate control of chronic diseases such as asthma. Therefore, therapy should really not be withheld if the patient requires it for control of their asthma. Long-acting beta-2 agonists are used for maintenance therapy for their bronchodilation and smooth muscle relaxation effects. Long-acting beta-2 agonists are not used as monotherapy for long-term control of asthma. Multiple Cochrane reviews have shown that the addition of a long-acting beta-2 agonist to an inhaled corticosteroid leads to greater improvement in lung function, symptoms, and less use of a short-acting beta-2 agonist than increasing the dose of the inhaled corticosteroid or using a leukotriene modifier. These are the long-acting beta-2 agonist agents available. We have Serofentiscus as well as Foradil or Perforomist. And the dosing for children 0 to 4 years of age as well as 5 to 11 years of age. Salmeterol and Formoterol have a duration of bronchodilation of at least 12 hours after a single dose, so these are usually given every 12 hours. Adverse reactions of long-acting beta-2 agonists include tachycardia, headache, hyperglycemia, muscle tremor, hypokalemia, and severe life-threatening or fatal exacerbations.
So this chart shows you the inhaled corticosteroid and long-acting beta-2 agonist combined agents. The inhaled corticosteroid component is what decreases the airway inflammation, and the long-acting beta-2 agonist binds the beta-2 receptors and provides the bronchodilation. These combination agents are recommended only for children 5 years of age or older, and you can see the dosing there in the chart.
Leukotrienes are potent biochemical mediators, and they're released from mast cells, eosinophils, and basophils, and they contract airway smooth muscle, increase vascular permeability and mucus secretions, and attract and activate inflammatory cells in the airways of patients who have asthma. Leukotriene modifiers interfere with this pathway, preventing that bronchoconstrictions and airway inflammation. They are alternative but not preferred agents, and they can be given for treatment of persistent asthma and can be used as adjunctive therapy with inhaled corticosteroids. Montelukast is used for long-term control and prevention of symptoms in mild persistent asthma for patients 1 year of age or greater and can be used with inhaled corticosteroids as combination therapy in moderate persistent asthma. Zafirlukast is used for long-term control and prevention of symptoms in mild persistent asthma for patients 7 years of age or older, and it can also be used with inhaled corticosteroids as combination therapy in moderate persistent asthma. It's recommended to give at least 1 hour before or 2 hours after meals, as administration with meals decreases bioavailability. And a major adverse reactions of Zafirlukast is reversible hepatitis, so it's recommended to monitor these patients for any signs or symptoms of liver dysfunction. For montelukast, for patients who are 1 to 5 years of age, it's recommended to give 4 milligrams at bedtime, and for patients 6 to 14 years of age, 5 milligrams at bedtime. Zafirlukast, on the other hand, is only approved for patients 7 years or older, and the dosing is 10 milligrams twice a day for those patients. Another leukotriene modifier is the 5-lipoxygenase inhibitor Xyluton. Dosing is based on the product, with immediate release being 600 milligrams 4 times a day and extended release 1200 milligrams twice a day. It's only indicated in patients who are 12 years of age or older. And adverse reactions include elevation of liver enzymes, reversible hepatitis, and hyperbilirubinemia. Omalizumab is an anti-IgE monoclonal antibody, and it binds to circulating IgE, preventing it from binding to the high-affinity receptors on basophils and mast cells, decreasing the mast cell mediator release from allergen exposure. It's used for long-term control and prevention of symptoms in patients who are 12 years of age or older who have moderate or severe persistent allergic asthma inadequately controlled with inhaled corticosteroids. The dose is dependent on a patient's body weight as well as their IgE level before therapy, and it's subcutaneous administration given either every 2 or 4 weeks. Adverse effects include pain and bruising of injection site, dizziness, fatigue, arthralgia, as well as anaphylaxis, as it is a monoclonal antibody. Another agent is theophylline. It causes bronchodilation by smooth muscle relaxation from phosphodiesterase inhibition and adenosine antagonism, and it also increases diaphragm contractility and mucociliary clearance. Really, theophylline has mild to moderate bronchodilator and mild anti-inflammatory effects, and so it's not preferred. It's used as an alternative or as adjunctive therapy in combination with an inhaled corticosteroid in patients who are 5 years of age or older. You can see the dosing is listed below, and I wanted to mention that for our obese pediatric patients, the ideal body weight is used for dosing. Adverse effects of theophylline include tachycardia, nausea and vomiting, tachyarrhythmias, headache, seizures, hyperglycemia, hypokalemia, and hyperactivity. Routine serum concentration monitoring is essential due to the significant toxicities, narrow therapeutic range, and individual differences in metabolic clearance. The target level for asthma is 5 to 15 micrograms per milliliter, and a trough should be collected just before a dose after at least 1 day of therapy. Now we'll discuss the quick relief medications, which are used to treat acute symptoms and exacerbations.
So short-acting beta-2 agonists, like long-acting beta-2 agonists, bind to beta-2 adrenergic receptors and produce smooth muscle relaxation. They are the treatment of choice for acute symptom relief as well as for prevention of exercise-induced bronchospasms. And their adverse effects includes agitation, irritability, tachycardia, tremor, hypokalemia, and hyperglycemia, similar to long-acting beta-2 agonists.
The SABA agents include albuterol and levalbuterol, and both are available as an HFA inhaler as well as nebulizer solution. The nebulizer solution can be mixed with budesonide or ipratropium solution for nebulization in those patients who receive multiple medications. And the doses of these can be doubled for exacerbations. The anticholinergics inhibit muscarinic cholinergic receptors in bronchial smooth muscle and reduce intrinsic vagal tone of the airway. The anticholinergic agent is ipratropium, and it's available as an HFA inhaler as well as a nebulizer solution. Anticholinergics provide additional benefit to short-acting beta-2 agonists to relieve acute bronchospasms. However, they have not been proven to be efficacious as long-term controlled therapy for asthma and are really used as an as-needed basis. Adverse effects include dry mouth, dyspepsia, dizziness, headache, and cough. Now on to asthma exacerbation management.
So asthma exacerbations are acute episodes of progressively worsening shortness of breath, coughing, wheezing, and chest tightness. These exacerbations are caused by bronchial smooth muscle spasms, airway inflammation, and increased mucus production, and they're one of the most common indications for ICU admissions in pediatric patients. And risk factors for life-threatening deterioration that we want to look out for includes history of life-threatening deterioration, so previous ICU admissions or previous required intubations, the inability to recognize airflow obstruction, a history of poor asthma control, as well as older age patients.
Patients with acute exacerbations will need to be assessed initially to classify the exacerbation and determine where treatment needs to be provided. Patients with mild exacerbations will have a peak expiratory flow greater than 70% predicted or personal best, will have dyspnea only with activity, and these patients can be treated at home by providing prompt relief with their inhaled short-acting beta-2 agonist. Patients with a moderate exacerbation, defined as a peak expiratory flow 40 to 69 predicted or personal best, as well as dyspnea that interferes with or limits usual activity, may need to be treated at the office or the emergency department. Patients with severe asthma exacerbations, defined as a peak expiratory flow less than 40% predicted or personal best, a dyspnea at rest, and that interferes with conversation, usually require an emergency department visit and likely hospitalization. And patients with impending or actual respiratory arrest will be too dyspneic to speak, have a peak expiratory flow less than 25% predicted or personal best, and will require an emergency department visit, hospitalization, and possible intensive care unit admission.
So management of asthma exacerbations is based upon classification of their asthma exacerbation. For mild exacerbations, they can be treated according to their patient's asthma action plan. Most often, it's use of an inhaled short-acting beta-2 agonist by nebulizer or MDI. And if a patient does have a poor response to this, they may need to go to the ED. The physician may also consider a short course of oral corticosteroids. For moderate exacerbations, patients should be provided with supplemental oxygen, inhaled short-acting beta-2 agonist by nebulizer or MDI, as well as oral corticosteroids if they do not have any immediate response. Severe exacerbations should be managed with supplemental oxygen. Patients also receive high-dose inhaled short-acting beta-2 agonist with an anticholinergic agent every 20 minutes, or it can be given continuously. Patients can be given oral corticosteroids, and adjunctive therapy can be considered if there is no response. And for patients with impending or actual respiratory arrest, intubation is often required with mechanical ventilation for 100% supplemental oxygen. Patients will receive nebulized short-acting beta-2 agonists as well as anticholinergic agent combination, IV corticosteroids, and adjunctive therapy.
Asthma action plans are extremely important. They're a partnership with the patient as well as the family, and they're an agreement on the treatment of the patient's asthma as well as the treatment goals. It's extremely important to teach the patient as well as the family member how to use the plan, what daily actions need to be taken to control asthma, how to recognize early signs and symptoms of worsening asthma, and how to adjust the medications for worsening asthma, as well as when to seek medical care. And here's an example of an asthma action plan. And you can see there's different zones, the green zone, the yellow zone, and the red zone. And these will each tell the patient on how to continue managing their asthma and what steps need to be taken. And so the treatment goals of asthma exacerbations is the correction of significant hypoxemia by administering supplemental oxygen, the rapid reversal of airflow obstruction, and the reduction of the likelihood of relapse of the exacerbation or future recurrence of severe airflow obstruction by intensifying therapy and providing appropriate education. Treatment options include supplemental oxygen, again to relieve hypoxemia and maintain oxygen saturation at 92% or greater, providing inhaled bronchodilators to relieve airflow obstruction either continuously or intermittently, systemic corticosteroids to decrease airway inflammation, as well as adjunctive therapies such as intravenous magnesium sulfate, systemic beta-2 agonists, and Heliox in those patients who are unresponsive to the previous mentioned therapy options. And so here are the inhaled bronchodilators available and their dosing. We have albuterol nebulizer solution in HFA, levalbuterol nebulizer solution in HFA, and ipratropium bromide nebulizer solution alone, as well as with albuterol. And as you can see, the dosing can be intermittent as well as a continuous nebulization. These agents are continued until the patient's peak expiratory flow is greater than 70% their personal or predicted.
So systemic corticosteroids are used to treat the airway inflammation, and early administration of them is key, and they should be continued until a patient achieves a peak expiratory flow 70% of their personal best or predicted, or continued once their symptoms resolve. The corticosteroid burst is usually a duration of 3 to 10 days. It's a short course. So as you can see, there are two prednisolone products available, Prelone and Orapred. Orapred is the preferred agent when using an oral liquid because of its palatability. So the prednisolone base syrup or Prelone has a bitter taste due to the alcohol that's used for solubility, whereas the Orapred product has sorbitol, which makes it much more palatable. We have to remember children are more sensitive to bitter taste than adults, and as it is already difficult getting pediatric patients to take medications, it can be even more difficult if they don't taste good. So as a pharmacist, this is a great recommendation we can always make to help increase adherence. And you can also see dexamethasone is another corticosteroid option that's listed there, and this is often given in the emergency departments for patients not requiring admission. A high percentage of patients don't fill their outpatient steroid prescription, and some of them don't complete their course. Dexamethasone was looked at because it has a longer half life, and a meta analysis that compared 1 to 2 doses of dexamethasone to a 5-day prednisolone course found no differences in relapse rates. The dosing and equivalence between the steroids is different and varied, but dexamethasone is commonly used in the emergency department for these pediatric patients as a once dose.
And so adjunctive therapy is recommended in patients who have severe exacerbations that are unresponsive after 1 hour of intensive conventional therapy or for life-threatening exacerbations and to avoid intubation. Magnesium sulfate decreases movement of calcium across cell membranes and bronchial smooth muscle, which leads to relaxation and bronchodilation. It's also been shown to inhibit mast cell degranulation, resulting in the reduction of inflammatory mediators. Studies have shown that magnesium sulfate, when added to conventional therapy, reduces hospitalization rates in emergency department patients who present with severe asthma exacerbation, and it also reduces asthma scores and improves pulmonary function. The dose of magnesium sulfate is 25 milligram per kilogram to 75 milligram per kilogram, and it's given over 20 minutes. Adverse reactions of magnesium sulfate include infusion site reactions, nausea and vomiting, flushing, respiratory depression, hypotension, bradycardia, and muscle weakness. And if patients are receiving magnesium sulfate, they should be monitored closely throughout the duration of the infusion as well as after. Terbutaline is another adjunctive therapy option. It's a systemic beta-2 agonist. However, treatment with it remains largely unproven. Current evidence does not suggest an improved benefit from patients receiving IV beta-2 agonists compared to aerosol administration. However, if it is used, it can be given subcutaneously as well as a continuous IV infusion with a loading dose and then an infusion that's titrated every 30 minutes based on the patient's clinical response. Adverse reactions to terbutaline include hypertension, a pounding heartbeat, tachycardia, nervousness, and restlessness. Another option would be Heliox, which is a mixture of helium and oxygen. Due to helium's low density, it can improve gas exchange in patients who have airway obstruction, and it's really only used to drive albuterol nebulization into the lungs in patients with asthma exacerbations.
So other adjunctive therapy options includes aminophylline. It's given as IV loading dose followed by a continuous infusion. Therapeutic drug monitoring is required. And so it's really not seen very often anymore for the treatment of asthma exacerbations, and the guidelines currently don't recommend its use. Ketamine is a general anesthetic that has bronchodilatory properties. So the addition of ketamine to standard treatments for asthma exacerbations, especially severe refractory asthma exacerbations, has been looked at in case reports and observational studies, and they have found that improves outcomes and alleviates the need for mechanical ventilation. So it can be considered as rescue therapy in refractory status asthmaticus. It's given as an IV continuous infusion, and adverse effects includes increased bronchial secretions as well as emergence phenomenon. So often these patients will also be on a sedative infusion to help prevent that emergence phenomenon.
Now we'll discuss delivery devices. It's important to discuss delivery devices in pediatric patients because a lot of these patients will not be able to use the inhalers properly without assistance. So the first one we'll discuss are the metered dose inhalers, which are the most common inhalers. These require a slow inhalation and coordination of actuation during inhalation, and this may be difficult in young children. Patients who are less than 5 years of age should really use these metered dose inhalers with a spacer or a valved holding chamber to ensure they receive the appropriate dose of the medication. Spacers or valved holding chambers are recommended for patients who have difficulty performing adequate metered dose inhaler technique. Spacers and valved holding chambers slow down the delivery of the medication from a metered dose inhaler. It allows for the medicine to be held in the chamber before it's inhaled. This way, the patient can inhale the medicine in one or many breaths, depending on their ability. For patients who are less than 4 years of age, it may be beneficial to use a face mask, as these patients may not be able to form a proper seal with their lips around the mouthpiece, and using a face mask ensures that they receive the medication. Once a child is old enough, the spacer or valved holding chamber can be switched over from the face mask to a mouthpiece.
So, next we have dry powder inhalers or DPIs. These are usually reserved for patients who are greater than 4 years of age, as they require more forceful inhalation to mobilize that dry powder into the lungs. This technique can be difficult for children to perform consistently and correctly. And so it really is reserved for those patients who can control their inhalations.
Nebulizers are used for patients of any age who cannot use a metered dose inhaler with a valve holding chamber and face mask. Nebulization utilizes a nebulizer which transports medication to the lungs by the means of mist inhalation. The nebulizer changes the medication from a liquid to a mist so that it can be more easily inhaled into the lungs. And it requires less coordination and cooperation from the patients, and is really the perfect way to administer medications to our younger pediatric patients and infants. If you have any questions, please feel free to contact me. I have my email listed there. And thank you for your time.